I think we'll get started again.
Yep. You folks all set? Not too sleepy from this morning, huh, with all the sleep stuff? So this afternoon we're going to take another little twist and we're going to talk about where. Where? What's that all about? But as we talk about this stuff, you're going to see that there's a lot of interaction with sleep. I can't separate the two, but most of it is going to be on a lot of cases you're seeing where people have these burned out mouths, and the first thing you're going to say is Bruxism. Not so. So let's go through that and see if we can put you back on that bicycle again and have you stay on the bicycle this time, okay? So you see this patient. What's the diagnosis?
Acidic erosion.
I hear acidic erosion. Anything else? I hear parafunctional habit. Just bruxism. GERDs. Bulimic. Good, good. If you look at some of these areas, if you say just parafunctional habits, there's a lot of places where there isn't any articulation at all. And then when you see this total destroyed mouth, then the concept is, well, you've been grinding your teeth a lot, right? That was the old concept. You know, you must just be grinding your teeth. There's a lot more to it, and we're learning more about this more than ever. And I have to thank Dr. Ward Noble from the school. He's done a lot of work on this background, getting a lot of stuff together on wear and the different types of wear. So you look at these cases. Any of these cases related to bruxism? I mean, these teeth aren't even touching. How can it be bruxism? So if you're looking at all this, here you have cervical breakdown, here you have incisal wear, cervical wear, destruction, and then you have an anterior open mouth. So when you're looking at this and you're trying to come up with some idea of A, how am I going to help the patient? To help the patient, you're going to have to know what's causing it in the first place. If you don't know the etiology, it's really hard to go in there and help these people. Here's that open mouth case again. You can see, I mean, they're almost into the nerve of the tooth itself. And you look at this and you say, why just here? Why don't I see stuff going on back there? Who said, did someone say bulimia? Yeah. So with bulimia, you get projectile vomiting, right? Where does that come from? It comes from the stomach. What comes out of the stomach? Hydrochloric acid. pH of hydrochloric acid is about 1.2. I mean, you can burn the rust off a trailer hitch with that, okay? So you have a very acidic throwing up, if you would, and it's projectile vomiting, so it breaks down all the front teeth. But the sad part about this young girl in 2007 looked like that. And several years later, she has what she has. Along the line, no one made any attempt to figure out what the hell was going on. Is it just watchful and waiting that we do a lot in some of these cases? Because we really don't know. So this is sad, because if someone counseled her years ago, she never would have gotten to where she is now. So now she's got this, and what else does that do? What does she have to do to swallow? Tongue has to come forward, right? So now you start pushing those damn teeth even further forward because of the pressure of the tongue every time she swallows. So these are some of the things we've been doing, watchful and waiting over years and years and years, and we're doing a lot of this internally. You look at these guys, and we're here, destruction, there. This is a lot from these old PFMs, the porcelain against these guys. So as you're restoring this case, Okay, this was restored here. Do you have a loss of vertical dimension? Or can you restore it the way it is now? If you have a loss of vertical dimension, I don't think you did because these gold crowns have kept it open, but look at the height of the tissue here compared to back here. So we have compensatory passive eruption on those lower anterior teeth. So the vertical doesn't have to be changed, but what are you going to do down here? You've run out of restorative space. So either we intrude those teeth, or we have to go in and do some gingival stuff to get down a little bit more crown-root ratio. But my point is that when you're looking at these and you just see this type of destructive wear, it's really not an easy diagnosis all the time. You really have to sit back and say, what was the etiology causing this in the first place? So if I'm going to restore, I have to have some idea what I'm restoring to. So in a case like this, I said I think the vertical was okay because all the gold crowns, they haven't changed. And this to me is compensatory super eruption, so you can do it in that vertical. So what did all these cases have in common? You get this stuff, you get the stuff, you get the little girl. Dental wear is an acid disease. Have you been aware of that concept, or is that new? Are we back on our bike? Is it a new bike for us all that we're trying to work on? So this presentation is just to kind of open up the thought process, is that when we see this, you really have to understand that the main culprit here is acid. And you have to understand that there's acid, and then we have to just say, where's it coming from, and how are we going to deal with it? I mean, you can go in here, and if you just put some class 5 restorations in here, do you think they're going to stay? More than likely not. So you have to go back and say, what caused this in the first place? So since it's an acid disease, we have to either control the acid that's contacting the teeth, or once the acid is in the mouth, how are we going to protect the teeth? You can look at it and even do both, but you have to get some idea, where's this thing coming from? Is it extrinsic acid, or is it intrinsic acid? So then you kind of know who you're dealing with, okay? So tribology, have you seen this word before, tribology? It's a science of wear, friction, and lubrication, and it's saying that when two things are rubbing together, depending upon the type of wear, it depends upon what's the lubrication between it. So if it's just saliva, that's a two-body wear with saliva, but if you have food or something abrasive, or even the type of dentifrice you have, and we'll talk about, and I'm glad Crest is here today, dealing with the type of dentifrice, you'll get some idea of maybe there's something you should be telling your patients about not only the acid, but how you can prevent. There's been a change over the years in vertical wear, and in a normal mouth, in 30 years, physiologic wear is maybe about 1 millimeter. Some of these patients have worn 10 times as much. It's not physiologic, it's pathologic. And so the whole thing attacks, it's the acid attacking both the enamel and the dentin, breaking parts away, and then when you get in there and do what you're doing, the wear on the teeth is magnified once all of this structure has been softened by the acid. So you need acid, you need the abfraction, the attrition, and all that, but the end result is almost 10 times quicker wear once the acid has broken down the outer layers. So those of us are saying, instead of restoring, what else do I have to do? I have to get some idea of where this acid is coming from. So breaking down is 2 portions. As I said, the acid erosion softens everything, and then your parafunctional habits, your attrition, your abrasion, does its job at a much quicker pace. Have we seen cases like this? Do you guys have cases like this? This has probably been observed for years and years and years. And most of all, the patient will say, oh, I'm fine, nothing's hurting me. And then they finally come in when they're so broken down and say, oh, my wife says she can't see my front teeth. Can you fix my smile? After all those years, right? And now you're left with this to work on. And say, oh my God, how did you get there? Do you have to increase the vertical dimension? Do you have enough clinical restorative space? What's the acid attack? Where's it coming from? And then the attrition goes in there and does its job. This shows that not only is the material between the teeth a concern, but as the load increases, the wear also increases. And there's a difference whether you have saliva, whether you have citric acid. So the wear increases by the type of lubricant you have in between the teeth and the load that you're putting on it. Multifactorial, here you have PFM crown. Look at what it's done to the gold. So here you have abrasion. Here you have kind of a little bit of erosive type where it's surfing down, and then you've got attrition. So there's always several things going on at one time, but the bottom line on a lot of this is that somewhere along the line, acid has been involved. What causes your class 5 restorations? Why do you think people get the cervical abfractive lesions? What's our thought? I know when I went to school, Grippo's studies said that when you have parafunction, you have balancing interferences, you get a bending of the tooth at the cervical, and then little pieces of enamel just break off over a period of time, okay? Studies came by Abrasive and Dvorak, and they're saying, no, that may have a little bit, but a lot of these things are caused not only by your toothbrush, but by the dentifrice that you have. Dentifrice, toothpaste, okay? So we'll talk about that a little bit too, because we don't think about it. We just give out samples of what the people live us, right? These are free, here, take these. So there may be a combination of that, but those later studies are saying that, no. But to me, being old school, I still see sometimes cracks. Do you guys see cracks coming down on those balancing cusp interferences? So I think there may be a little bit of it, but you have to now also add the concept of acid and toothpaste. So this is, total destruction. You can't say all of this is just wear. It is, but again, to beat the same drum, acid has taken its place. So what's the difference between caries and erosion? A lot of it is acid. Caries will survive up to 4.5 pH. Erosion, you can take it down, down to 3. And so there's a difference in the lesions. There's no bacteria here. There's bacteria here. So there's a difference in the environment. And why don't you have any caries? Because you had so much acid in your mouth that the bacteria can't survive. You're below that 4.5. So when you see a case like this is not caries giving you a problem, folks. This is acid that has attacked these teeth, and then you've done your parafunctional habits, and that makes the disaster even worse, okay? The biggest thing we have coming up are kids. With these sports drinks, we used to think soda was the biggest culprit with this phosphoric acid in soda. The acid in these sports drinks is much more destructive. And these little guys, want to be like their favorite players, so they're chugging down their Gatorades and whatever. Even 5-year-olds, 13-year-olds, this survey overall, 30% of them in this meta-analysis found wear on these young kids. And it's all due to the acid and the way that it's been drunk. So when you look at someone with erosive tooth wear, and you see them maybe at age 70, 75, and you're looking in their mouth and you're saying, oh my God, you must be grinding your teeth and you have all this wear. We're looking at this point in time. This is an accumulation of stuff that may have happened over the last 30, 40 years. And we're just seeing it now. But what if years ago, bulimia could have been taken care of, stress dealt with, GERDs dealt with, and now many of our elderly people are on multi medications, so that does what? We get xerostomia. And if you don't have the acid doing what it's supposed to be doing, then that affects the teeth also. So when you look at a patient with all that wear dentition, don't think it was just this snapshot at this point in time. It's been an accumulation over years, unless it was someone like that young girl we saw. This is kind of scary. First time in a long time, our patients may outlive, the teeth may outlive the patients. Years ago, edentulalism was up. Here, they're getting older, and if we don't take care of what's going on, we're going to see edentulous. But I'll show you demographics showing that we're at a point now where it's in a little bit of a balance. So here's some demographic studies. 1960, you can see the baby boomers are down here in the red. On this side, female, this side male. And then you have the years. So if we go to the 60 to 64, look at the number of millions if you come down, and then look at the people over age 85. It's not that many. But you go from 60 to 80, look at how that's starting to expand. And the sad part is, more women are living longer than men. It hurts me every time I see that. And then you see the baby boomers starting to move up the scale, okay? That's 1980. So here's 2000. Look how this is widening in these upper years. Look at over 85. The women are up to about 4 million. And this is getting wider. This whole base is getting wider. So as we're moving up, people are living longer. Looking at 2020, baby boomers have moved up. The women are up to over 5 million. We're trying to catch up. The bottom line is that people are living longer. So people are living longer, they have their teeth longer. We're looking at that saying, what do we have to do to keep these people happy? Do we still maintain the same concepts we had before? And so one of those concepts that we have to take into consideration now is this acid thing. Edentulism. You can see how it has decreased over the years, from 46% down to about 17. Most of it, this is the darker area here, most of it is in this area here. California is white. At least we're first in something, right? We're last in school and reading and math, but hey, edentulism, where we have less than anybody else. Thank God for something, right? So people are keeping their natural teeth longer. So we see more patients with wear, and they're outliving their teeth in a sense. And this is the type of destruction you're going to see slide after slide after slide. And you're going to have to realize that these potholes that you see, that's not from wear, that's acid. And the acid.
Can I ask you a question?
Yes.
How do they maintain, is that just from super eruption? Is that from continued eruption that he has so much wear in the front and not in the posterior?
It could be. It could be how the acid is coming up, if it's a bulimic type of acid that comes out straight. It could be the drinks that they're drinking. It depends on where the acid is coming from. But if you have a lot of gold crowns in the back, most of the time that's going to maintain your vertical dimension. Most of the time, okay? And the wear, because of the acid, comes up in the front. And those teeth are going to super erupt to try to meet their neighbor so that they can chew on stuff. So you see a lot of compensatory super eruption on the anterior teeth, unless the acid is going all over. And then on these back teeth, these are all these hollowed out lesions. That's acid invoked. This is the acid plus the wear. So it's a whole different, do you see a lot of these patients up in this area? I mean, you're in a wealthy area here. You see a lot of these elderly patients now maintaining all of this, and they're hard to go in there and restore. Multiple medications. I feel a lot better now that I stopped taking all the pills you gave me. How many of our patients are on polypharma every day? Pills and pills and pills and pills and pills. What happens with a lot of these medications? What's the biggest side effect on a lot of them? A lot of xerostomia, huh? So if you have xerostomia, you're going to get a decrease in decrease in saliva. And one of the main functions of saliva is what? Neutralize and buffer acids, huh? So you have an effect which is even more so on all these people who are on all these multiple medications. Everything from Vicodin to Ambien, Zoloft, and it's just like they get up in the morning, they have these handfuls of pills, I have patients coming in, I said, would you fill out the history on your medications? They pull out this typewritten sheet. Usually it's one, I'm on, blood thinners. What am I going to do with this thing? Can I do anything to you? I mean, I'm afraid to touch you. You've got, 54 medications you're on. But anyway, that's polypharma. Saliva is the most biologic factor in erosive tooth wear. So oral clearance dilutes the acid, buffers the acid. Supersaturation of calcium and phosphorus helps to build the pellicle, which covers the tooth. And your type of saliva is the risk factor for your caries and your acid erosion. Severity depends upon the pH of the acid. Is it coming from the stomach, where your pH is 1.2, 1.3? Is it coming from one of the sports drinks? That's up going to be about 3.2. So one is a lot stronger than the other. So where's it coming from? And then how is this drink taken if it's an extrinsic source? You just swallow it, or some people squish it around in their mouths. Okay, the longer you have the contact with the tooth surface, the more destructive it is. Okay, and then with dehydration, you have a problem, and the thickness of the pellicle is influenced a lot by the quality of your saliva. So if you don't have good saliva, folks, the pellicle is weaker, you're under acid attack, your acids aren't buffered at all, and they just kind of build on one another. This is the swish side. Either that, or sometimes it's the side they sleep on, and if they get acid coming up from their stomach and they sleep on that one side, this side is going to have a lot more destruction than this side is going to be, because the acid just pools there all night. So, hey, do you sleep on your right-hand side? Yeah, how did you know? Well, your teeth told me. They did? Yeah, you're sleeping on the right-hand side. Perfect storm. You have a patient who's a Bruxer, he has a sleep apnea, he has GERDs, he has medication-induced hyposalivation. Typical guy. So how do you go in and treat this? You just take care of his teeth. You have to deal with everything else that's going on. And this patient profile is changing because we're seeing in younger people, we're seeing you don't have to be obese, and we're seeing you don't have to have the neck size of 17. As I said before, we have these very tall, thin, gangly models who maybe eat once a week. I don't know when they eat. And we're finding out they have apneic problems also. And that's because this long tube can bend, and as it bends, it's like a garden hose. You break off part of it and tighten part of it, okay? So don't just think by looking at someone you can say, boy, exactly, you have a problem, or you don't, or you do, or whatever. You won't know until you talk to them and you do a little bit of a survey. So the weird thing about this, again, is that there's no bacteria, and the acid can come extrinsically or intrinsically. And sometimes in people, it comes both ways. Wow, US is at top again. This is how many gallons of soda we drink individually per gross domestic product. And as the gross domestic product goes up, the wealthier we are, the more we drink. 50 gallons? Someone in here is taken my other 49 because I don't think I smoked 50 gallons of. I don't drink this stuff to begin with, but wow, you know, and it went up in 5 years from 40 gallons up to 50 gallons, and again, the more wealthier countries. But then you wonder, you know, people over here, is it just indigenous in, you know, how they were brought up and stuff, other than the fact that they can't afford it, or is their mindset a little bit different? That they'd rather drink tea or something other than those sports drinks or the acid-containing sodas. So here's a change: energy drink and soda. So in the black is 2009, so you can see that energy drinks took over, and at the same time, soda consumption went down. So we've gone from drinking more soda to drinking more of these energy drinks. And you see that more in the young kids, and that's why you see some of the breakdown in the kids that we're seeing. You know, parents are great. Let me put the kid on energy drinks. It's got all the vitamins, all this other stuff. It's got Gatorade and force. Yeah, but what's the acid and the sugar like in these things? And that's the important thing you have to consider. Which is the least erosive out of these four people, do you think? Red Bull? No, it's the soda. We used to condemn the soda, but the phosphoric acid in there is less than the acids that they have in these sports drinks. So the soda is less, even though it's not great, but it's less erosive than we see in these sports drinks. Okay, so we have teeth, extracted teeth, put in these solutions, and it has the amount of dissolution over a period of time and their acid. So you can see where your colas are down here. These guys are up here. A friend of mine owns a bar, and he was selling so much Red Bull for the kids with all their mixed drinks. How do they put it in everything, I guess? He's tired of opening the can, so he's going to put it on tap so I could be faster. Almost 3 months, he had to change all the lines because it was corroded. So this stuff goes into your stomach, and these kids are drinking this thing like water. I see my students. 8 o'clock in the morning, they've got a Red Bull. You know, and it's like, okay, you know. So, I have a proposition, and it's worth real money. I think it's real money. Let's see. So, for $50, who wants to come up in 5 minutes and chew and swallow 17 cubes of sugar? Any takers?
Who's going to take me home and put me to bed?
I mean, just seriously. I got the money. Come on up, chew these things, swallow them down in 5 minutes, you got $50. Damn it, someone said something. What if I said for $50 you'll come up and drink this? It's got the same amount of sugar. You won't eat that, but you'll drink this. No takers? I haven't had one person take me up on it. 100 threw me off, but I've not heard that before, so. But anyway, you had your chance. Thank God, I don't think I had $50 anyway, so. But that just to show you that how we are duped by a lot of advertising and stuff, and we just don't look at labels anymore. We just think, hey, it's, it's got vitamin C, or it's got this or that and the other thing. We don't look at the sugar, we don't look at the acid that's in a lot of these drinks. And there's your other favorites. You can see the acid content, the amount of sugar in them, Cokes, and even orange juice. Why is having a glass of orange juice maybe not the healthiest thing to have? How many oranges do you think are squeezed to give you a glass of orange juice? So, yeah. Would you sit down and ever eat 6 oranges at one time? Your body says, that's not natural for me yet. Yet we gulp down this orange juice, and all the sugar and all the acid of 6 oranges at one time. And it's just a mindset of thinking a little bit differently and saying, what am I putting in my body? And I'm not big on I'm big on nutrition, but I'm not a tree hugger and all that, I'll eat meat and everything else. But just to give you some idea of some of the destructive things going on. So here you go, when you see a label, 4 grams of sugar is 1 tablespoon. 4 grams of sugar is 1 tablespoon. So a Monster drink, you have 27 grams, so it's about 6 tablespoons. Coke has about 40, so that's almost 10 tablespoons. 10 tablespoons of sugar every time you have a Coke. That's kind of, but then they put all this other good stuff, vitamin B12, vitamin, blah, 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 and, sugar, okay? So just being a little bit concerned about what you're drinking and how you're drinking it. Look at how the demand for sugar has gone up over the last 10 years. And the problem is, most of the time, it's in everything that we don't know. I don't think we add sugar to a lot of stuff. They just sneak it in on everything on us. We don't even know we're eating the stuff. And so that's a problem. Just give you some idea what sugars are in various products, even in yogurt. And the sugar gulp, we're looking at about maybe 600 calories a day from sugar. And you can see, go number 1, USA, okay? And some of these other countries have much less sugar in their diet. But again, a lot of it, I think, is they just sneak it in on us, I don't see too many people adding sugar to a lot of stuff. It's just in everything. Say again? We eat more processed food, exactly. And I'll show you a little chart that shows that. So these are 2 books. Talked about sugar and how they're sneaking it in and how indirectly it's killing us, I guess, along with everything else, okay? And yeah, they're easy reading. So intrinsic acid. So the intrinsic acid comes from the stomach, GERDs, and it comes up in the form of bulimia, anorexia, alcoholism, and it's kind of the strongest of all acids, okay? So you're talking about 1.2, 1.5 pH. And that's really strong. GERDs is gastroesophageal reflux disease. And when you see this type of stuff, and you ask them what medications they're on protein pump inhibitors, your Nexium, your Prilosec, and all those. We know that that's just not wear from grinding your teeth. Something else is going on. And a lot of times, sometimes they're on the Prilosec and stuff. Sometimes they don't even know. And the physicians don't know enough to look in their mouth and say something else is going on here. And that's where we come into play. We see these people all the time. Our hygienists have to get away from just talking about nonsense when they're cleaning their teeth. There's so much they can educate the patients with. And I'm not against hygienists, but I'm just thinking, are you a hygienist?
I told her we should be talking nonsense.
Well, I'm going here, I'm going there. Have you tried this wine? Someone has a sale. That's good to establish rapport. 34 seconds and then you're done, right? But there's so many of these things now. Hey, I went to a presentation, they were talking about this. Do your kids drink these juices? Here's a little chart. Have you take a survey for your kid. Little things like that could make a huge, huge difference. I think it brings a lot more to your appointment because of the education you had, and I think you're going to be utilized more and more and more and more. In most of the offices, the hygienist is probably the first line of defense in talking to the patients about this. Most of the time, the docs don't have enough time. We'll do the survey, this and that. And then someone in your office has to be the person that can carry the conversation just a little bit further, because patients are going to want to know more. And maybe the person at the front desk or the second person at the front desk can talk to them a little bit and say, this is what we see, this is what we normally do. Because if it's going to take time away from your treating patients or your productive time, you're not going to do it. That's what I find. There has to be somewhere we can be handed off. You can be the initial person, or maybe it's the hygienist who does it. But there's usually a conversation has to be held a little bit for these people to get on board. And I'm a consultant in a large office, and I'm trying to tell these people, they have like 20,000 patients. And I'm trying to tell them, God, even 20%, you used to have 4,000 patients that should have sleep problems. And trying to get the front desk and the doctors in the back to come together and carry this forward is a real problem. Because the doctor said, once I start talking, then they start talking, and it takes away from all my productive time. So that's why I've said, have the survey. If they score high, say, if you're really interested, talk to so-and-so at the front desk. So we have a person at the desk who takes over all the sleep stuff. And so it doesn't take away from the doctor's productive time, because that's one thing I think will hold people from doing that. So where does the acid come from? The acid reflex, you get a relaxation of the sphincter, and the acid comes up. Do me a favor, kind of take a breath. Okay, now block off your nose with your fingers and take a breath. What's happening? What do you feel? Do you feel pressure in here? Are you able to feel that pressure? Okay. So if you're not breathing properly, either nasal congestion or whatever, you're building up this interthoracic pressure, and that puts a lot of pressure on your sphincter, and a lot of times you get some GERDs coming up just because you're not breathing properly. I know I wasn't talking about sleep, but it all comes together, guys. It's all the same ball of wax, okay? So then the sphincter doesn't work, and you have that very strong acid coming up into the system. We put acid on teeth all the time, but here we know why we're doing it. We're doing it for a reason, right? But what if you get that constantly, and we're not doing any composites? It's the same type of a destructive process. So they react differently. Your enamel is mostly inorganic, where there's more of a balance in your dentin between your organic and your inorganic. And so they react differently to acid attack. Okay? After an acid attack, the calcified material is removed. Then you have this very, very open tubules. So after you have like a sports drink or stuff for your kids, you tell them go and brush their teeth, right? Is that a good time for them to brush their teeth? No, because now you've softened everything. So you have to wait at least a half hour. The other thing you can do is try to neutralize a little bit. They can squish their mouth out with water, or they can chew on some cheese. The cheese will change the acidity a little bit, and that's something you can go to, okay? But I know we're so concerned. You just had that drink. Go brush your teeth. The worst time to do it. Not only for kids, but also for us. So just be aware that you're very, very open to acid attack once you've had one of those drinks where the acid has come up. And it affects the enamel and the dentin, and it's these open tubules. And I'll kind of show you why. Our lady from Crest is back there. I'll tell you why I like their products and what they do. So the differences, as we just said, there's a difference in the mineral content, so the destruction that they have on the teeth is a little bit different also. So nothing happens to the tooth that happens in the saliva. So you have the saliva of high quality forming a very strong pellicle over the tooth, which is now very resistant to decay. If this isn't working right, or if the acid in the system is so low, these pellicles now covering the tooth are very weak. So you're more susceptible to decay and everything else. So the saliva is king. And we said before, these are the things that it does, and it's a big risk factor for decay and a big risk factor for erosion. This kind of says a little bit of the same thing. Oh, the contact time, as I said before, is important, whether they squish things in their mouth. Brings a point in the wine tasters, especially white wine. As they're tasting their wine, they swish and spit it out. They must do 50 of those a day. Their front teeth on a lot of these people are really atrocious because they have this constant acid attack from the wine. And in Austria, which I may move to, If you are a wine taster and these front teeth are broken down, you can have it repaired under workman's comp. Yeah, so there you go. Yes, sir. The composition? Well, you have both all the mucins and the proteins in the mouth and all the contribution from the phosphorus, the calcium and the phosphorus from your saliva, and that forms your pellicle over the top, okay? If you reduce any of those, that pellicle is thinned a lot and it doesn't have the ability that it has normally. Okay? Say one more time, sir.
Does it have some structure, some unique structure with respect to all the components that you just mentioned?
I can't answer that question. Maybe somebody else can. I don't know what the structure is called. There may be some formulation that gives it a name that I don't know. Sorry, I don't know that one. So we talked about this again, the same thing, this interaction. This just shows you more destroyed teeth. And sleep bruxism. Is sleep bruxism the same at night as it is during the day? Bruxism is bruxism, right? You just grind your teeth. It doesn't matter when it does, right? There's a difference. On these people, if you do a night guard, does that stop their parafunctional habit? Mrs. Jones, you're grinding your teeth. Here's a night guard. Doctor, will that make me stop my grinding? Yeah. No. The habit is there. They're still going to do it. The only thing is that you're protecting the teeth from wear. That's essentially what you're doing. But you're not stopping the habit. So don't tell your patients they're going to stop parafunctioning. They're not going to. Because that's an inbred habit, and all we have to do is deal with it. And there is a difference, as I'll show you, between whether you brux during the day or whether you brux at night. So which one of all of these do you think was pure bruxism, as pure as it can be? Yeah, okay. Good, you guys are getting great. Yeah, so here, I don't see much of an acid attack, but this guy really goes to town on these teeth, right? Huh? He's chewing grass? I know. It's called cowclusion. Difference between cowclusion and crocodile occlusion. These are clenchers, these are bruxers, right? So there's a difference, right? And all these others, you can see all the wear patterns on a lot of these, okay? Think of bruxism as a wear problem, not just grinding. If it's wear, look at where the structure is, and is it a place that you can actually get to by grinding your teeth? And if not, acid has a big role. And is it a sleep bruxism, or is it an awake bruxism? Are there some environmental problems? Some of these people who work in these factories where they're outdoors and they have a lot of fumes in the air, like they're doing all these chemicals and stuff, and they're breathing that in, that breaks down the surface of the teeth. And how about these kids who are swimming in these chlorinated pools all the time? I don't know, just a thought. So you can make an occlusal guard, but are you really getting to the bottom of the problem, huh? So what do we see in bruxism? In sleep bruxism. We see a lot of tooth wear. We also see a lot of hypertrophy of the muscles of mastication. And I'll show you, if I get to the gnathostomatic stuff, why that happens. Hyperkeratonics of the cheek and tongue as they bite their cheeks, and you can really tell by doing EMG studies to see that they are bruxing. So self-reports, mostly from your partner, that you grind your teeth, you get muscle tenderness, temporal headaches. So when you do your exam, you get a new patient or you're going to recall, and you're doing a head and neck exam, right? So we're palpating the joint. I like to sit behind the patient, so when they're opening, I can see any deviation of the mandible from side to side. I have my hands on their joints, I'm listening for sounds, and then I slide down and I have them clench. I have them come up here and I have them clench. If these are quite hypertrophic, unless the patient, Mrs. Jones, you clench or grind your teeth? Oh, why do you say so? Here, give me your hands. Have your patient bring their hands up and have them clench. Oh my God, what is that? And up here, have them clench. Do you get a lot of headaches up here? Yeah, I do, but I have migraines. You have migraines like this? They're not migraines. Migraines aren't bilateral. Migraines are unilateral with prodromal signs. These are muscle contraction headaches. Come from you clenching your teeth. So when you start to talk to them about making them a night guard, if it's purely just that, Mrs. Jones, remember when we were examining your face and stuff and you felt those muscles? So hopefully, with this little piece of plastic, the stress that you put on that system is less. And hopefully the spasticity or the hypertrophy in these muscles will get softer for you. There are some people that do it so much, you can actually see a change in the facial shape. It kind of comes down and here it sticks out a little bit more. I mean, and when they clench, you see like these two little golf balls coming out, right? That's not normal. That's not normal. So being able to talk to them about that is great. And self-reporting, most people will not admit to clenching and grinding their teeth, but their spouses will. So you can't get away from it. Look at this guy's masseters. Gee whiz. It almost reshapes his face. And this shows the where RMA episode. Okay, let's talk about that. Rhythmic masticatory muscle activity, RMMA. So when you're asleep and you go into your apneic episode, what happens at that time? Who gets nervous? What part of your body gets nervous when you're not breathing? Brain. The brain says, I'm not getting any oxygen, you're going to die. So you better start pumping faster, heart. So your heart goes into tachycardia to get more oxygen to the brain. During that period of time, the brain is saying, you're still going to die, you better wake up and take a breath. So it sends a message down to the trigeminal nerve for you to start clenching and grinding. You start clenching and grinding and you wake up and you go, the jaw comes forward, you take a big deep breath. Okay? That's why in a lot of these people with sleep apnea problems, you see a scallop tongue. Have you seen the scallop tongues? Okay? So now you're in fight or flight. The heart's pumping like hell, your jaw's moving like hell, right? You're in fight or flight. The trigeminal nerve is boom, 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 and now you got to calm yourself down. So now the vagus nerve comes in, and the vagus kind of brings you down to homeostasis again. What if you do that 100 times a night? Any reason why people die in their sleep? Or people have undiagnosed cardiovascular problems, and they haven't had a sleep study done to see if that's contributed to them in one way or the other? Just a thought, okay? But it's important that a lot of the heavy parafunctional stuff that you see is due to a sleep problem. And that's what forces them into those factors. Now here's daytime bruxism. It's different. The nighttime is your circadian rhythm and your desire to stay alive. The day is related, it's under your control, it's just that you're doing all these weird things. You're biting on a pencil, you're clenching, you're nervous, you're putting your jaw here, there, whatever, but you actually have control over those. The nighttime you don't. So one is a centrally located problem, and the other is more peripheral. Okay? What do you tell your patients that grind during the day? I find myself, I'm driving to work and I'm like this, just like this. Damn person always cuts in front of me, right? So if you make a traditional night guard and there's nothing else going on, they can also wear that night guard during the day. As long as you stay within about 10 hours, between night and day, stay underneath 10 hours, you're okay. What happens if you go over 10, 12, 14 hours? What are you fearful of? You're fearful of losing the proprioception that says this is where you belong, and you may get some bite changes, okay, that are irreversible. So it's important that you'd stay under that 10-hour thing, and they can wear it during the day. The other thing is I can tell my patients, look, when you find yourself during that, I'm going to give you a mantra. You know what a mantra is? Okay. So the mantra is lips lightly together, teeth apart. And you can hum if you want to. What does that do? The muscles aren't firing. What if I put my tongue in there? The muscles fire. I don't want anything touching. So lips lightly together, teeth apart. Okay? In a crowd, it may be weird, but at least you're not clenching, okay? And the more and more you do that, the more you're going to find yourself doing that and hopefully self-correct yourself. So getting back to this, we talked about the acids could be out or in the mouth, and then we add the grinding of the teeth to it, and then there's the behavioral thing like the grinding of our chewing of our nails. Episodic sleep, not too much there. So it can be physiologic or pathologic, and as I said before, the physiologic wear of your teeth in about 30 years is 1 millimeter. Your pathologic wear can go up to 10 times as much for these people who have all these other problems. So a little bit of wear may be normal over the years. The excessive wear is not. And these are some stories showing physiologic wear. I used to know what the green meant, or the red, I don't know anymore, so that's okay. So what has happened? So as we changed from hunter-gatherers to where we are today, so there's changes here. The base is the same, but we have huge masseters, huge alveolar bone, straight teeth, and oh my God, functioning third molars. Then over here, same base, smaller masseter, smaller alveolar bone, crowded teeth, and packed third molars. So years ago, we didn't have these problems. And a lot of it has to do with, we were hunter-gatherers here, agriculture, who's had food processing before? In here, and this is where we are today. So what's happening on the scale? The attrition has stayed about the same, but the abrasion in some cases has decreased because we don't have to chew our food as much. It's all highly processed yuck, okay? But look what's happened to the acid and the caries, okay? So, you know, if we were Neanderthals, there wouldn't be any work for the oral surgeons, right? Because everybody had their third molars. I was invited out to this company called Vivos Life. It's a company out of Denver. And their whole thought process was that they felt that every child born was a perfect class 1 relationship. And then through epigenetic changes, which is environment and everything else, changes occurred which changed the upper and lower jaws. For example, if your baby just slept on their back with their head, you know, as the back of the head gets flattened, that also puts pressure on this whole system here. It affects the way this grows, and they go into their class 2 or class 3 relationships. And then his thought was that if you put these appliances in people's mouths and you break open all that contact, you wear these appliances 24 hours a day, the stem cells remember where they came from, and that they go back and they reform, they put you back the way you were before. That's what they said, okay? Just throwing it out there for a conversation when you get together with people. You can bring that up, okay? Are your stem cells going back to where they were before? You could ask them that question, right? So anyway, that was their concept. But anyway, a lot has to do with going through this process, and we're here. And I guess when we get into outer space, everything will be through a tube of some sort. I don't know. This whole concept started in 2010, Jeff Rouse, prosthodontist, one of the only smart prosthodontists other than Ulf. I told you I'd have to bring up your name one time, right? All right. Ulf's a great prosthodontist. You ever need a good prosthodontist? Ulf Timitzer, check him out. So he came up with this concept that sleep apnea, GERDs, and sleep bruxism are all in the same triangle. And then Dr. Noble and I were talking, and we said, yeah, but we want to put saliva in here with the pH, and what happens with dental wear. But Rouse was the first guy who came up with that concept that all these things come together that way, and he was right on. So sleep bruxism, that we talked about, and awake. This is, the awake is non-functioning. That's, I think we related to that a little bit. Physiological, as we said, is centrally mediated. It's because of the changes in that RMMA I talked to you about. So sleep cycles, sleep breathing, sleep grinding is all related to you're not sleeping appropriately. You can see by some of these studies, they're trying to catch up on who bruxes and who doesn't. You know, there's a big difference in children and adolescents, the percentages, but what shows over a period of time, a general concept, is that as we get older, there's a tendency from these reports that sleep bruxism gets less over a period of time. Do we know why? No, but these are just, you know, a 70-year-old patient is probably not from bruxing. A 70-year-old may have a lot of breakdown to all the polypharm and everything else. I think more has to be done in this area, but that's the results up till now. Sleep bruxing factors, you know, how do you go to bed? A lot of caffeine, alcohol use, your personality. Do you snore? Do you have gastric reflux, hyposalivation? And all of these have in common is that they all disturb normal sleep patterns, which leads to sleep arousals. I told you I wasn't going to talk about sleep, but I can't get away from it because all these things go back to it. Okay, so I apologize for that. All right. When you ask patients if they brux, they say no, but if you run tests on them, 35% do, and they're not aware of it. So interviewing them by asking them directly, most of the time, 50% of the time, you get the wrong answer. Ask their spouse, you get a much better answer, okay? So there's very poor correlations between the bruxism, those that think they do, and those that actually do brux. So Ward was talking about not calling this bruxism as a diagnosis, but actually calling it erosive tooth wear, because that's really what it is. It's a combination of those two factors. This I think we saw before. Wear is not a good indicator as we sell. That's not good. I'm repeating some of these things. The EMG is the only standard really that we can put on people's muscles to say if they're really grinding and bruxing, whatever. Just asking them, as I said, makes no sense. But EMGs are the best. Cause and effect. So I already mentioned this. I jumped ahead. This is that RMMA that I was talking to you about, where the nerves get involved, the muscles get involved, the microarousals, and most of our people with those scallop tongues are doing this, and most of the time they don't realize it. So here's the normal sleep cycle. So we start at stage 1. Actually, now they're combining 3 and 4, but here's stage 1. Low voltage, you're sitting there. The guys who like to fall asleep in the chair, you know, watching television. You go into stage 1, and you're just kind of there. And you hear your wife coming, and you know that if you stay right here, she's going to think you're sleeping, right? Right? Well, you're really not. You're just in that stage 1, right? And she looks, oh, he's probably sleeping. I'll hide my honeydew list, right, so I don't have to disturb him, right? So you're in that early stage of sleep 1. Then as you get down to 2, you start getting down mostly into slower wave sleep, and this is your deep sleep in around here. This is where you get your quality sleep, and then you come up out of this and you go into REM, which is your dream cycle. That's where you do all your dreaming, okay? So remember I was talking about this part takes care of your physical body, and this part takes care of your dream cycle, your brain, okay? The other thing you'll notice is that most of the sleep bruxism comes where you're going from stage 2, you're coming back out of this, you're coming up from stage 2 to stage 1, and then you go into your REM. In around here is most of where the sleep bruxism occurs. You'll also notice that as the night goes on, these cycles get a little bit shorter, and you should do about 4 to 6 complete cycles a night. They last anywhere from about 60 to 90 minutes. But you can see your dream cycles now are getting closer, closer, and closer. And isn't the best dream just before you wake up in the morning, right? And damn, I was enjoying this dream, and now I woke up, right? That was the best dream I had all night, right? And you look over, your wife was wondering why you're smiling. You know, oh, nothing. You know, I just had my best dream, right? So, but it works for your ladies too, right? So anyway, so this is a normal cycle. Now, what happens if you're coming down here, you're just ready to go into your deep sleep, and you have a breathing episode, and it wakes you up? When you fall back to sleep, do you start here? No, you start back up on top. So you're not getting down into the deeper sleep times. You're getting a lot of stage 1, stage 2 sleep, but you're not getting down to that deep, deep, deep restful sleep. And that's because every time you wake up, you start at the top. Okay, so this is where sleep and obstructive sleep apnea come into play. It disturbs this normal cycle, and you or your children say, hey, I slept for 7 hours. Why am I so tired? It's not just the length of your sleep, it's your quality. Did you go through 4 to 6 complete cycles, or did you have all this fragmented sleep throughout the night? And that's what makes the difference.
Does that also happen with snoring, or is it just with apnea?
Snoring too. Or anything that obstructs your normal cycle. Because a lot of times when you start snoring, what do? The tendency to kind of move your body, or have your wife kicks you or something like that, and you have to roll over. It may not be as abrupt as your apnea, but depending on the degree of your snoring, how much of the oxygen is being cut off that starts the cycle, either clenching your teeth or starting you to move to something else. So when people say, I just snore, I'm not apneic, is that okay? I don't really know until you have a sleep study done, because I have to monitor your oxygen saturation in your blood during those periods of time. Are you getting into areas where the oxygen saturation drops that kicks off something that makes you move or breathe or open your mouth or something? So you cannot diagnose a person without a sleep study. You have to get a diagnosis from a sleep study. You can't get it from a survey, you can't get it from a spouse, you can't get it from the person. You have to have a sleep study. Okay, and that'll give you more information, or the only information. So you can see here there was an obstructive apnea. You can see what happened to the blood pressure. The muscles started to clench because the body was going into oxygen debt. Remember years ago when we thought people would grind their teeth? There's some older guys in here too. Remember it was all occlusion? Remember that? Because of your occlusion, that's why you're grinding your teeth. So what do? We did a lot of full mouth reconstructions, right? Did the people stop grinding their teeth after we did full mouth reconstructions? No. So then we started thinking, well, maybe there's something else involved. So we got on the bandwagon with stress, and you're grinding because of your stress. Okay, and now that's being taken over by sleep. There still may be, I'm not saying that balancing the occlusion doesn't help the teeth themselves, but does it really address the bruxism? I think no. So what we do dentistry-wise, all the great things you do, you're making this whole gnathostomatic system happier, but you may not be changing a problem with sleep bruxism if you're doing it because of that. So it's still important, but it's not as important as it was years ago. This you can kind of control, tell the patients. Most of the time they don't know they're doing it, and we can get involved there. So this is that triangle again we talked to you about. Intrinsic acids, acids that originate in the stomach with GERDs. We see it a lot with anorexia and alcoholism. And a lot of these acids, depending upon how the acids come out, will wear certain parts of the teeth. Bulimia, since you have this projectile vomiting, a lot of it is on the linguals of the upper anteriors. The other acids, depending upon if it comes up and it sits there, what side are they sleeping on? It may affect it on one side or the other. And as I said, the gastric reflux is up there. And the problem is, once you break through here, it's not only the acid here at the valve itself, but your entire palate and the roof of your mouth is irritated by the acid. So it's not just a localized little thing. You're sending acid up that whole esophagus, and everything along the way gets burned, especially if it happens over and over and over again. So you see mouth problems, dental erosion, sinusitis. You can go up into the sinuses. It wakes you up because of the acid in your mouth. Barrett's esophagus is a precancerous lesion. You damage the airways, cough, laryngitis, non-cardiac chest pain. So just by having that acid come up, the entire scope of your esophagus is involved. And a lot of these people just keep taking Prilosec. So what are we going to change? Behavior, watch the food you're eating, watch your weight, cigarette smoking, stress. You know, there's some of the things you can tell your people about. How do you tell your people, hey, you're under too much stress, cut it out? It's like, what do you do? You know, how do you eliminate stress? Okay, that takes a lot of work. But you can mention that if they can change behavior, that may help. So there's a close evaluation between GERDs and dental erosion, and between dental erosion and GERDs in a lot of the patients. But look up here, look at some of these studies, 25 to 83%. That's a big, that's a big scan of people that are in that study. But preliminary studies on this stuff, and starting to see more and more people with GERDs have erosion, and more people with erosion have GERDs. Protein pump inhibitors, PPIs. 100 million prescriptions a year. I happen to see, first of all, these things are you on these things for life? Most patients take them as, hey, I've been taking Prilosec for the last 5 years, and I can eat anything. These protein pump inhibitors are supposed to be taken like 2 weeks at a time PRN, and yet people are living on them. I actually saw an ad the other night, I don't know what I was watching. It says, if you've been taking Nexium or Prilosec, and you now have a kidney functioning problem, call this legal office. Yowzer. First time I've heard that, okay? That's like, gee whiz. You know, and you don't see, you know, the advertisements of the, who's that comedian who's a repairman? And he's, and he's eating all this stuff, and the stuff's coming out of his mouth, you know, and it's like, yeah, but I take Prilosec, I can eat all this stuff, right? So, but anyway, so that's something we're going to look at. If we start getting law or legal cases against these drug companies because it's not advised or the patients aren't been advised that you can't do this long term, that may be a problem. When you look at this guy, what about this patient? Remember this morning we were talking about the convex profile, the high vaulted palate, okay? So internally this guy's having some sleep problems. There may be some erosion also, but now I look at these people, I've never seen this before. I'm more in tune now to those convex face patterns than I saw before, and you start getting some idea that these guys may be having sleep problems. So sleep breathing disturbances, snoring, upper airway respiratory problems, obstructive sleep apnea, and it puts you into that RMMA situation. And, you know, it's always, I don't know why they always say the wife is the one suffering. What if she was the snoring and he was awake? I want to see one of those. If I find one of those, I got to put it on my slide. Copy of seen it. The guys are always to blame. So we're looking at your patient. So what's actually happening? So normal anatomy, you have your adenoids up here, your tonsils down here, your normal airway. If you have problem with your adenoids, or the base of your tongue falls back, or if you have a long, droopy, soft palate, the air doesn't go through the way it's supposed to. When you look into someone's mouth, especially kids, and you see kissing tonsils, a long uvula, or a long, soft palate, you know, suspect some type of sleep disorder going on. It's embarrassing, and I'll show you, if I get to the anatomy part, that if you just think the obstruction is here, and you put people into a sleep device, and they're not getting better, and you haven't checked out the nasal portion, you may not be getting the results you want. Because the obstruction can be back here, but if the obstruction is up here, and you put them and bring the jaw forward, this is not taking care of the problem. So when you're doing an evaluation for sleep, it's important that you also look at the nose, ask them questions. Do you have a deviated septum? Have you had polyps? You have trouble breathing through your nose? And yes, yes, and yes. Have the check by an ENT first. It's really embarrassing to put them in an advancement appliance when the problem is really in their nose. So the nose is also critical. So what does the appliance do? We talked about this a little bit earlier today. So it brings the jaw forward, opens up the pharyngeal airway, pharyngeal spaces back here, and now clears the space where before the base of the tongue went back and blocked this space over. Many times we have a very, very long, soft palate, and this causes a problem also. But this is basically what you're doing with your appliance. And this is an EMA appliance, and you just change these little rubber bands depending on how far you want to bring the jaw forward. Again, the bruxism and upper respiratory patients, sleep patients related to this MMRI again, and the oral pH levels are related to how the saliva flows. So this again was a perfect storm we talked about before, and I'm telling you that also it could be ladies. We're not just stuck on this anymore. So years ago, the standard treatment for sleep bruxism includes a stabilization appliance. But if you just put in a regular night guard on a patient who has a sleep problem that maybe they're not aware of, is that good or bad? If you put a night guard in, a traditional Michigan-style night guard, the patient lies back. What happens to the jaw? Most of the time the jaw goes back, huh? So there's studies done by Gilles Levine and some of those saying that you may be exacerbating a sleep problem by putting people just into a routine night guard. So if there's a suspicion, and I got pretty nervous because I think I've done over 5,000 night guards. How many of those patients have I exacerbated their sleep problem, me not knowing it? So now, before I do a night guard, I have them do a little sleep survey. If I haven't had any problems, I'm doing a lot of work or reconstruction of some time. Have them fill out a little sleep survey. And if there's some indication that they have a sleep problem, please, 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 please do not put them into a routine night guard. I know you want to protect all those veneers. I know you want to protect all that stuff, which is critical. But a routine night guard may cause more of a problem. So normally we do it for sleep bruxism without, we don't, for treatment of wear, okay, active verified sleep bruxism, no. Awake bruxism, yeah, they can do it if they're awake. We prevent damage to the restorations, possible disorders. Night guards are like, well, I'll just give you a night guard. Guys, when you give them just night guards, so much more can be going on. They're just plain night guard stuff. So I have to be more careful than I was before. So the main problem with the night guard, if you have a sleep problem, it's going to make it worse. This is a design for people who need a night guard, but show maybe some early signs of sleep bruxism. So this is a design where this little palatal shelf comes down here on the anteriors. So as they sleep, it prevents the mandible from sliding back. So you may want to consider that type of a design if you're not sure whether there's a sleep problem or not. And it looks at that, oh, they're never going to wear that. You can cut this a little bit shorter if you want to. But patients, if you tell them why it's made that way, the information is critical, and they understand. So management of tooth wear, early detection is also important. Once you start seeing these little potholes forming, don't wait until it gets major before you get involved. You know, be aware of all of this stuff that we talked about before. And you can either treat Early detection versus extensive treatment. You can start off on this side, or we can also start now talking about how do you protect the tooth surface from acid challenges using topical stannous fluoride, not sodium fluoride. Why do I say stannous fluoride? We're talking about acids. Because in a high acid environment, the sodium fluoride is not as effective as stannous fluoride is. And right now, Crest Total Health is one of the few toothpastes that has stannous fluoride. And the samples you're getting today also have that. So you may want to think, especially in these highly acidic situations, what toothpaste are you either handing out or you're advising your patients to use. And the cue here is stannous fluoride. Shows that instantaneously, different types of products over a period of time, stannous fluoride protects tooth wear a lot more than sodium fluoride does. And that's because it protects the tooth from acid involvement, because it stays stable at lower pHs. Okay? We saw this slide before. So this is a slide on enamel wear. And you can see, here's your Crest Pro Health, Crest Cavity, Colgate Total, Sensodyne, and Arm & Hammer. Now, Arm & Hammer works a little bit differently. Arm & Hammer says, I'm just going to neutralize the mouth, but it doesn't do anything to coat the teeth and prevent the teeth from sensitivity from the acid attack. I think Colgate is now looking at putting some stannous fluoride in a lot of their products, but as of yet, actually, you know, back there, is Colgate putting it into their product yet? Do you know? Say again? Is it the same? I heard it was a different formulation.
It's their stannous fluoride. We're going to say that we've been working with stannous for 50 years. We understand it a little bit better, but they haven't released it yet.
Okay, so they're starting to see the light and hopefully change it. And I don't know if I heard their formulation isn't as good as the one in Crest because they've been doing it now for 50 years. But start considering this, and you can see some of these others, especially like Pro Enamel is amazing that that causes more wear. If you're looking at treatment again, here's high concentrations of fluoride, stannous fluoride, like in your Crest, sodium fluoride, Prevident, and even at the higher levels of sodium fluoride, the wear is much greater than those with stannous fluoride. So just a thought. I wish I worked for them, but I don't. Anyway, it's just like, what is a better product and why? Okay, that's my point. So stannous fluoride, this is a visualization of a surface here. You treat this with sodium fluoride, and then you hit it with acid. You treat this with stannous fluoride, and you see there's a lot more protection around the tubules. It almost forms a coating around the tubules, and that's why the sensitivity of the tooth loss is less. So it doesn't expose the internal inorganic stuff as much as the sodium fluoride does. And to me, it looks like carpets. I don't know, every time I saw it, it looked like somebody's carpet in a hotel. But the difference is your sodium fluoride leaves a lot of open tubules. Your stannous fluoride is a way to ablate a lot of those tubules and therefore decrease a lot of sensitivity. Here's the Crest Pro Health again. And you show the stannous fluoride, the effect, the sodium, and then the control over there. pH drops precipitously very quickly. Not too much there. Demineralized dentin, it really has a big effect on your demineralized dentin, and it protects a lot of the collagenous membranes that are there, other than being destroyed by the sodium fluoride. So this is critical. No matter what dentifrice you use, look up the relative enamel or the relative dental abrasiveness. You can go on any toothpaste, they have to say what's the REA and the RDA. And that is more important than actually the stiffness of your brush. The pH levels and the abrasiveness of the paste are the most important. So if that level is 250 or less, it's a relatively good toothpaste, okay? If it's above 250, you've got a very abrasive product, and it's going to cause a lot of cervical wear. And so especially in mouths where you have your acid attack. CG has MI paste, and a couple other people have MI paste, and they go in there and they remineralize after erosiveness has done its job. So the best thing to do is brush with your stannous fluoride at night and in the morning, but after you brush with your stannous fluoride and rinse, then get the MI paste, and with your fingers rub it around everything, spit out the excess, but don't rinse. Let that MI paste sit on those teeth all night. That has a great role in remineralizing the structure. So the best that I think is there when you have these problems is the MI paste to remineralize, and this is CG's. A couple other brands have the same thing, a couple other companies. And then before, go in there with your stannous fluoride and cover those tubules over, okay? Varnishes are good. This is one by Colgate, and this Colgate varnish actually does have a sodium fluoride in it. Prevident is the varnish. And some of these smaller lesions, there's nothing wrong with putting sealants in there. If they're real small little potholes, cover them over with the sealants. And the sealant actually repels the acid more than the natural tooth structure. So those little potholes we saw as we were doing this, go in there and fill those little guys up, okay? You just abrade it a little bit, etch it, wind up a little bit of sealant in there, and don't wait until they get real bad. Have you guys done every saliva checks? Buffered saliva? No? Who wants to check their saliva? Okay, I knew this group would. Okay, come on down, I'll hand these out to you, okay? I think I only have 19 of them. So, ooh, look at all that stuff, okay? Let me kind of show you. Over there. Oh, there it is. Okay, so here's saliva check. So the kit contains, you people who are there, you have a pipette, a pH strip, color chart, pH indicator, buffer, test strip, and wax. And so let's say you have the patient, you have them open their mouth, dry out the lower lip, and then see how long it takes for the saliva to come back onto the lip. It should be less than 60 seconds, okay? So let's pretend you did that. Now, get a little cup, spit into the cup, and then with the pH strip, check the color chart there to see how acidic you are. So get a cup, spit into the cup, get your pH paper.
Is this the pH paper?
Yep, that's the pH paper. So put in the cup.
Here's your pipette.
There's your pipette. I love this organization here.
Pipette.
That's good, okay. Okay, so everybody has, so when you're ready, spit into the container, put your pH paper in there, and then measure it against the, isn't it so ungirly like to spit into a container, right? But that's okay. Is that all right?
I'm glad it's not brown.
It's not like brown. Actually, you should do this, and they should wait for an hour before they've eaten anything, but what the hell, we'll run ahead, okay? So put your pH paper in there, and then you guide it against the color wheel there, okay? Leave it in there for about 10 seconds. And you can do this with your patients. This is great, especially patients that have a big acid attack. You want to know how acidic is their saliva. You can't tell just by looking at it, right? Say, hey, guess what? We're going to do a saliva buffering test. Right?
Mine's healthy. Mine's healthy.
Oh, who cares?
Damn, I saw yours hers and I'm like,
Yeah, she was.
I was like, hers is bad.
Why's yours?
I just got done chewing Trident.
Oh, there you go.
Just a second.
Okay. Maybe that's the secret.
I'm a cheater.
Mine didn't.
Well, are you near the pink? Well, there's kind of a, you look, maybe these little guys in there. So you're on the borderline. Yeah.
I don't know.
Okay.
So I'm like really good.
You're not really good. She's really good. You're just good. She's really good.
So right here, I have a question.
Yeah?
What are your thoughts on SLS? Because a lot of the dentifrices have SLS.
What is SLS?
Sodium
Oh, okay. Allison!
Yeah.
What is it, the foaming? Yeah. I think the new Crest has that. Yeah, it does. So I think it's great. It emulsifies and it gets things bubbly, which is good. In what way? Really? Really? I haven't used it, so I don't know, but I know it's a newer product. Yeah. So maybe they're using too much, I don't know. I'll have to ask her.
We got the Colgate Inhabited Dry Mouth prescription toothpaste, and it's SLS free. Because we were having
But Colgate is sodium, not stannous. Okay, so we've done that. So now you chew the gum. There's a little piece of wax in there. These are the wax containers. So you chew that for 5 minutes, and you keep spitting. You keep spitting, then you measure how many millimeters of spittoon you have in there after, okay? So you don't have to do this for, 30 minutes. So after about 5 minutes, what you then do is use your little pipette, and you get your pipette and you put it on these guys, okay?
I gotta open another one.
It's okay. What'd you do, chew it?
No.
Oh, you swallowed it?
What do you want us to do?
Yeah, so keep spitting it out. Then open one of these strips. There's a strip inside. You have it? Good. And then with your pipette, pick up a little bit of your saliva with your pipette and put a drop into each of those little containers. And then use the same color wheel to see if you have buffering in your saliva. Okay?
All three?
Yeah, put one on all three.
That's really not tasty.
What, the gum? I didn't say it was. It's just wax.
It's like flavored gum.
Yeah.
Like unflavored gum.
Remember those lips?
Yeah, the plastic gum. So while they're playing, what's the purpose of all this? It's to say, what are we treating? Do you have a very, very non-buffering type of saliva, which magnifies all the other things that we're doing to try to keep your mouth away from the acids? So while they're having fun, well, that one is from GC America. They sponsored having that here. I was supposed to have 40 of them. I only got 20. So anyway, what's in the box is your cup. You spit into the cup, use your pH paper. You measure that. You keep spitting. You chew your gum. You keep spitting. You measure how much spit. And then with a pipette, you pipette a little bit and you put it on this saliva buffer strip. And then you gauge it against what color it turns. So the patient can also see this is what your saliva buffering is like, and we're finding a very acidic solution, so we highly recommend you use something to fight off the acid. So a lot of these things are, you guys remember Robert Barkley? Man, he started stuff years ago, right? He said, goal of dentistry to make patients worse at the slowest possible rate. That doesn't sound very positive to me, but anyhow. A lot of these things we're getting into minimally invasive preps, and a lot of them, if you do them, they're easier to do. Look what's happening over the years, over these 5 years. Porcelain fused to metal crowns, these are laboratory reports, went from 65 to 60. All ceramic went from 33 to 80, and we hardly do cast gold anymore. So what's happening in the field is we're getting away from porcelain fused to metal, going to all these ceramics, and as you know, because of bonding and adhesion, our prep designs are totally different. We can be a lot more conservative with our prep designs. You don't have to go down to the gingival sulcus, and you can go in there and do reasonable dentistry. So the take-home lesson, think in terms of tooth wear as loss due to acid, not just bruxism. And this may give you some idea of how to treat your patients, especially the patients who have all that destructive stuff going on in their mouth. Find out the acid, are they buffering, put them on a strong stannous fluoride, use MI paste, do the initial restorations while they're small, and if you're doing anything at all and you don't balance the acid, long term, your restorations are going to fail. So a lot of the reason why these restorations fail is because of the acid in your mouth. Okay? Any questions? How are you guys doing over there? Is anybody normal except her? Hey, psst, stop talking. Is everybody normal? Anybody not normal? That very normal?
My observation was that how much better my saliva got only chewing wax.
Yeah. So that's what you're going to chew now, wax.
So it didn't matter if it had xylitol and all
Yeah,
this stuff,
yeah,
like the gum
yeah.
and the nut.
Well, that's why you're supposed to do this, and you should not have eaten or had coffee for about an hour beforehand, okay? So then you're dealing with people with the clearest saliva they possibly have, okay? But it's a good strengthening when you show them, look at the colors you have, and you're talking to them about the different types of fluoride or the MI paste or whatever. It kind of makes sense, other than you just talking about it, okay?
So MI paste has the two, the plus or the regular, so you
Yep.
recommend the plus with the
Yeah, yeah, I do, okay. Okay, let's take a break. You guys okay? All righty. How's it going, my friend? Yeah.
At UOP now, do you do any qualitative or quantitative measuring of saliva at this point in time? That kind of test or any?
They do,
like
yeah, they
How do you
do.
measure if somebody has a dry mouth?
just a reminder to everyone, we have cookies back here if you want to throw caution to the wind. So, thank you.
Okay, folks, let's get started. Are we all ready? So at the beginning, I mentioned two sponsors. The one is Kettenbach, which is back there. The other one is Contact Ease, and I don't have their products here, but there's a bunch of brochures. So if you want to pass this around, these are great little interproximal things for your composites, taking away stain when you're doing hygiene. And if anybody's interested, I have that code up in front. Before you leave, if you want to see it, you get 20% off just by being here today. So I just pass these things around. You can take a look at them, okay? They're great people. They're out of Portland, Oregon. The other thing is, have you guys heard of aqualizers? Aqualizers? So what these are, they're actually little water-filled splints. So for people to come into your office with a hot situation, a hot joint, or they woke up this morning and this side, their teeth are not touching, but it's touching on this side, what are you going to do with these people? What can you put in their mouth? What are you going to do? You can put them on, non-steroidals, of course, packs, but they're saying, I can't touch on this side. So what's happened during the night? Something happened when moving their jaw that this head of the condyle came down. You have a synovitis or a swelling in the joint, and the swelling in the joint pushes the head of the condyle down, so when they close, this part doesn't touch. Can you put a regular night guard in their mouth? Make up the space? The regular night guard is going to keep the space, right? So what the alkalizer does, there's two, I'll pass these around. There's two little water-filled tabs. So the plastic goes across here, and then the tabs go over the back teeth. So you're biting down on these tabs of water. And so what it does is it allows this to come back to where it was before because it adjusts to the water that's in there. So it's an emergency type of splint for people who are having those problems. And you keep these in your office, and they're Aqualizer is the name of it, and I love these things. They come in a couple of sizes, small, medium, and large, usually medium and large. But in those times when you have these hot cases, you don't know what to do, this is great to have around to kind of bail you out of trouble. So if you want to kind of pass those around, please, thank you. And here's one over here, my friend. You can look at that and pass that back. Thank you. Okay, no more products. But I love to show you things that I use because I think they work. And having been in facial pain for a number of years, I wish I had these alkalizers years ago because you just never know what to do when the patient is just touching on one side. But if you understand why that occurs and why you can't put in a regular night guard, it makes a lot of sense. The regular night guard is going to keep it open. You want this to come back again. The splints, as you're biting down, that water squishes away. You can then close over a period of time. It also gives them a place to be equal and chew on that side. So anyway, that's for you to use. So I'm going to talk about something similar to what we just did with wear. And again, Ward and I worked on some of these. NCCLs, non-carious cervical lesions. These guys, okay? And again, it goes down to what causes them. And the old Grippo effect was it was all occlusion, when they're starting to think that it could be the abrasiveness of the dentifrice along with your brush causing it. So don't call them abfractions. They don't involve bacteria, and a lot of these are difficult to say, is there erosion involved with it? Is there acid coming down? And the answer is yes. So these guys, remember we used to go in there and say, if I see something like this, man, it's got to be traumatic occlusion. So let me put the restoration in and adjust the occlusion. But if the occlusion wasn't the problem and you still have the acids, they're going to come back again. And the acid will get around your restoration, break down your bond. And don't you get sick of replacing these things over and over again? You know, sometimes you replace these class 5s over and over again. So the secret is it could be acid that's attacking them. 62% of the population, and most of these abfractions you're going to see up here in the elderly, more so. Again, medications, xerostomia, all those things that affect the acid saliva balance in the mouth will make these a little bit more prominent. Look at some of these guys. I mean, this tooth is ready to break in half, right? How do you treat these things? Or why was this left to go to where it is today? Well, we can only treat what we see, and we have to know what we're seeing. And we could look at these things over the years and say, well, that's going on, but I'm not quite sure. You must really be brushing hard, right? And so, never thinking of the acid, right? Again, a lot of times they become sensitive. As it goes, breaks down into the cementum, and you start getting some recession. And again, it affects the tubules. So, have you seen these guys with the aesthetic problems? So what are you going to do with these guys? What are the choices? Putting in all class 5s, and many times having to go back there and repeat that class 5 thing over and over again. And the problem here, though, is acid and these other things causing these class 5 lesions. Okay? I know you've heard that 15,000 times.
Question?
Yes, sir.
So on the previous slide, you have abrasion abstraction.
Mm-hmm.
Going back to the slide that you showed for opening up the discussion on abstraction, my understanding was that the abstraction is the more geometric loss of cervical structure versus abrasion, which is a more curved, smooth architecture.
Yeah, hold that question. Let me show you. I think when you see that sharp one, there's an occlusal problem that's causing the bending at the cervical, along with the acid attack.
And I have oftentimes seen abstraction
Uh-huh.
on teeth that are not under any occlusal force
Mm-hmm.
in overclouded condition,
Right.
where you're just
Yep.
lost for an explanation as to what
I know what you're saying, yeah. And now I'm looking at it and saying, there's acid. Most of the time the acid has a very subtle effect, but you see those sharp, 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 and I always think of this, what Grippo was talking about, but you're right. Sometimes you look and you say, I wish I had an answer for you on that one. I don't, but I know exactly what you're saying. Does anyone have any idea why we could get that if there's not trauma? How about a prosthodontist? Any idea of maybe?
Well, it's a multifactorial, right? So there's several factors working together. As mentioned earlier, what I know is this theory of abstraction incorporates enamel. Often those class 5 lesions are way below the CJ. So there's no enamel to break off anyway.
Okay. So, do we know exactly what's going on here? But I just think many times it could be a bunch of things, but I agree with you. When I see this sharp, sharp, sharp lesion, and I don't see occlusal problems, that concerns me. I wish I had an answer for you on that. I don't. Yes, sir.
Buccal abstraction theory first came out in the early 90s. Did a scanning SEM study, showing that there's some breakdown in the matrix of the tubules due to tensile and rotational forces on, the cementum layer, cementum and dental layers. So then the tubules were getting separated. Now, has there been a change in that theory?
Well, what causes that? My problem and our problem is what causes that tensile strength to cause that?
Occlusal.
Yeah, but occlusion isn't a problem. That's what we're saying. When we don't, if you see the occlusion, it makes sense, right?
You see a lot of it when you also have occlusal attrition as well. You see correlation of it.
Well,
Before that theory came out, we always talked about it as toothbrush erosion.
right, exactly. Yeah,
Toothbrush paste.
right.
So when I saw that slide, I go, wow, maybe you can give me some insight on this. But again, I see a lot of it when I see a lot of occlusal wear as well, and also when people are grinding, through the cuss tips. And a lot of people angle class 2 division 1, where you don't have canine rise or incisal guidance, and you have a lot of root function back. I see a lot of that.
Yeah. Yeah. And that's why when I saw the study by Abrasive and the other guy, Dvorak, I forget his last name, I'm thinking, well, I always thought that I saw stress fractures coming down those cusps, you know? And they're saying, no, it's all this other stuff. So I'm in the middle of the road, and I just think there are two ways of looking at it. I'm not 100% sure, other than just that there is. I've never considered the acid component before, and now I consider that.
I'm the same way. I
Yeah.
can't explain it.
Right.
When they came out with that theory, it seemed like the most logical.
Mm-hmm. Right. Right.
I've always been like, what is this happening?
Exactly. No, I wish I had a good answer for you, but I don't. But this is, the old theory with Grippo. And, this is the enamel the breaking away at the CEJ, and you get those very, very sharp lesions. I hope I had a good answer for you. I don't. This is, it shows it's related to occlusion, especially your excursions, hitting on those buccal cusps and causing the tooth to flex. Here's our friend again. So when you have abfractions, abrasion, again, you're saying there's a lot of sensitivity. And what caused it, and as I said, they said it's not so much the bristles, this is the study by Abrasive, but it's the relative abrasive factor of the dentifrice. And so they've run these studies, and they had them in vitro. They had the teeth, and they had the brushes going, and they did it without the dentifrice. They did it with the dentifrice, various types of dentifrices, and then they graded all the wear and the different type of wear, and that's how they came up with that, okay? So, take it for what it's worth. That's how the study was done. Yes, sir?
Whitening toothpaste is more abrasive?
Most of the time they are, okay? The whitening, they keep adding stuff. I keep running out of names. They keep changing these things every 2 weeks. They added the foaming thing now to the crest, and I was asking our lady back there, because you said there's a lot of irritation on some people, and they said that they experienced that in about maybe 10% of the population. And it's just I tell them this is not the toothpaste for you. And the reason they put the foaming action in there is to drive the stannous particles. Because of the foaming, it drives them deeper down into the gingival tissues to help fight bacterial invasion. So that was the philosophy behind it, okay? But if some people have somewhat of an allergic response to it, they say, hey, this is not for you. But that was the kind of the mentality behind it, okay? So in some people it's going to work great. Other people, hey, there isn't one thing for everybody. Yes, sir?
Seems like with these, if it's a true abfraction division, filling is probably doomed to fail again.
Yes.
Should we be considering full coverage instead?
Boy, that's a tough question. If you have a totally virgin tooth, I think I'd rather tell the patient, look, I'd rather be conservative. Because of the situation, these things are breaking. It may be some acid, I'm 100% sure. This thing may come out, we'll do it again. But I'd rather be conservative other than cutting down the whole tooth. That would be me. If you have something where you have large restorations and you already have a tooth that's been pretty much cut away, you may want to consider that. But I would consider, it would hurt me to cut back a perfectly good tooth just because of the abfraction. Okay? Why is it worse on number 28? Pardon? More time? I'm going to brush only 28 today. Pardon? Yeah, the prominent root. The tooth is out further in the bone, and so as they're in their brushing, that just gets more of the aggravation. Okay, so that's something you may see. This just tells you where the remineralization, demineralization, enamel, and dentin, they start breaking down at different pH levels. And so the erosion is non-bacteria, where your decay has bacteria. This just shows the effect on the tubules. Nothing there. Oh, here's a question. Is this patient right-handed or left-handed? You see this, and that's the other side. What do you think? You sure?
Because you always have more tears on the side that we're brushing.
What do you guys think? Right-handed? Left-handed? I looked at this, and I've done this several times, right? And I'm thinking, I do it on myself, okay? So if I'm right-handed, why am I getting more over here if I'm left-handed? And I don't know. Huh? I just find myself kind of doing the same on both sides. But anyway, this question came up, and it's just like, there's got to be a definite answer, right? I throw this up because I don't know. And I know I'm supposed to say I have a definite answer, but trying it on myself, when you go home tonight, you may want to say, hey, am I brushing harder on this side? Or am I brushing harder on this side?
But we are dentists.
But we're... Does that make us different? Yes. We brush differently?
Yes, we do.
I have a friend of mine, he said, I brush, 15 seconds, I'm done. I said, 15 seconds? He said, yeah. He said, I'm a dentist, I know where I have to go all the time, in 15 seconds I'm done, right? So it's like, because we're dentists, we know how to do it faster, right? Yes, sir.
They had cross-section studies about 30 years ago on that, and they said it wasn't just so much because the motor coordination was better on the same side, but because that when you looked in the mirror, if you brush on the same side, your hand got in the way, you didn't look at yourself, you couldn't see yourself. And when you brush on their side, you looked at yourself, and people are basically, they like to look at themselves. And that's why they brush more. When they could see themselves, they could grin at themselves.
Yeah.
That was what they said.
That's interesting.
What I asked you is going back to buccal abfraction. We also know McCall's festoons we have, and we have a lot of lateral tensile strength. But you don't see a correlation with McCall's festoons and erosion there. So how do they explain that?
I don't know. I'm as much in this whole thing to me is, I hope somebody comes out with a study so that I can face shoot people and say, this is exactly what happens, right? I have to expose myself and say, I don't know, and that's okay. I don't know everything. But I'm just saying that just look at it differently, and the thing I guess I want to get across is there's a mechanical component, but there's also an acidic component. Just keep that in mind, and as you restore, you may want to tell your patients, because of the high acid in your mouth, these things may have to be redone again. If there's an occlusal component, we know how to deal with that, right? And so right now, I'm in the middle of the road, the way you guys are. And I don't know in these studies recently that comes out with a definitive double-blind study saying this is what actually happens.
Also, they expect more animal crazy, and you don't see that either.
Again, I don't know how to answer your question, okay? No, I know where you're going, and I'm saying I don't have an answer for you, okay? So I want you to do a study for me, okay?
I was hoping I saw that you would tell us something. I'm waiting for that breakthrough.
Okay, if I do it, I'm going to send you, Richard, the first letter goes to you, okay? No, but that's a great point, because we fight these things every day. And, we have a mouth, we have people, everybody's different. Everybody's physiology is different, they respond differently. You can't cookie cutter. We're not like people coming off the Ford assembly line where all the cars are about the same. And so that comes into play. But no, seriously, on a serious note, I hope they come up with some great answers. We talked about this. Some of these things are repetitive. I don't want to go into that. Multifactorial. Prevention. Oh, here's another thing. You talked about that, but we talked about early intervention. There's also, we also talked about don't brush for at least 30 minutes after you have something acidic. We talked about that. We talked about Crest. Here's a white varnish. And there's a varnish by Omni that has 5% sodium fluoride in it. So that's a good varnish to use. SP3M also has another varnish you can use. And one of these is a prolonged contact. So you can also hit that with a curing light. So that's a little bit more, that lasts longer than some of just the paint-on varnishes. Okay, so some you just paint on, some you can actually hit with the curing light. Sealants work in these very small lesions. Again, we talked about this person. Consider the factors, nothing new there. I wanted to get to, grafting. Did you ever consider grafting over these lesions? Because if you're doing all these class 5 lesions, you've got pretty good stuff here on the enamel as far as your millipascals of adhesion, right? What happens when you go up onto the cementum? Are you going to get as much adhesion in those areas? And the answer is no. So some people will come down and they'll graft this area. And this is a 2-year study. Comes down 2 years. And if you do some little stuff here, it's not as bad as doing that whole thing. So you have a little better area of potential success. Here's another one, periodontal coverage after a year. Takes care of that large abfraction. Another one down here on that crazy tooth number 28. And here you can do almost a full case. You can go in there, do surgery all the way across. You can even put down a additive tissue there, but then you're going to wind up with 4 weeks later, you've got this healing, and you're going to later go back and maybe just do those 2 cuspids. These are 8 months later. So considering maybe periodontal surgery or root coverage may be a better way of going. Just a thought. But you also have to evaluate and say, have we changed their habits as far as their acid intake or the intrinsic, extrinsic acids? Okay, that's critical also. So just don't look at this as a one-trick pony. This is just something else you can do. Another post-op. So treat reasonably. If you want to do, just put class 5s. I'm not against it. You can do just simple little things just to keep the patient comfortable and happy. So I think the biggest thing is, what am I treating? What's bothering the patient? Is the patient someone who wants to be conservative? The patient wants to be a little bit more aggressive? You have to consider the patient, and that's kind of the bottom line. So bringing some of those concepts forward, you may have a little different attitude on how you treat them. Bottom line is I wish I had a definitive answer to give you, but I don't. And so take it for what it's worth, okay? I think I'm going to stop with that one right there. Yeah. So the things that went around, did everybody see the aqualizer? Did you get a chance to see that? I would definitely, they're very inexpensive. They're a couple bucks a piece. Definitely get them in your office. I think they'll get you out of a lot of trouble, especially with those people where they have unilateral open bites that came on traumatically. To contact these things, that's up to you also. Okay, so I am finished with this section, and we're going to move along a little bit because I don't want to keep you guys real late, okay? You want to stand up for a moment or so? You can while I just reboot.
Regarding your last slide, the dean at my school had told me that the best, success in dentistry is time between intervention.
The success, yeah.
I mean, it
Brought back memories, huh? Fantastic. So I'm going to have an auction here, and since they did the study with the saliva, they get to have the aqualizer, okay? There you go. That's your prize for, all right. Okay, Gox, let's do one more thing. And this is kind of a combination. This is kind of a combination of everything we've talked about. So some of these slides you may have seen before, but maybe we have a little bit of a different concept on them now that we've gone through all this. So I call this the perfect dental storm. And you guys remember George Clooney and the Storm, the movie. Huh? He didn't make it, right? Yeah. So what did George do? You know, he's watching stuff, knew all this stuff was happening, putting it off, looking at something, getting these, you know, getting back with the catch they had, ignoring a lot of the signs, you know, and is that what we do in dentistry sometimes? So my point is, you know, a lot of times we do watchful waiting, and where we should be maybe more aggressive and at least educate the patient. So George didn't pay attention, so George wound up almost underwater, right? Holy crap. Why didn't I do something before, right? So with that in mind, we talked about this triangle from Rouse, and we're starting to see this relationship as it's all tied together. This affects that, that affects this affects this, that affects that. It's all interwoven, and you can't many times just separate them. This was Jeff's concept, and talked a little bit about the difference between those who grind their teeth at night and those that do it during the day. And this Bruxism triangle that he calls it is detrimental to the teeth, and we've seen this now. And some of the things he didn't put in is what Ward and I put in, was the acid and the wear. Structural loss, okay, that we know. So we added to his triangle both the saliva pH and the effect on it erosive-wise, when all those things were working together. And now you're getting a little bit of an idea of how this all comes together, more in a package. And this is what we've added. So wear is the end product, and it's the end product of all these things put together. And it's so hard to say it's just here, or it's just there, or it's just here. We're now looking at this entire picture, and I think we're much smarter for it, because I think we're able to tell our patients and give them a little bit more education. We've seen these problems. We know that this is not wear. You don't function up here. That's pretty clear. Bruxism is not a diagnosis in itself. Bruxism, to be effective, needs acid. And pass some of these. We talked about tribology, and we talked about this. We talked about gastric reflux and how acidic it is. We put you through that. We talked to you about some of the things that the reflux does. And this is actually a precancerous lesion that occurs from the repeated burning of the acid. We talked about changing your behavior. We talked about our friends and the lawsuit. Here's the slide I didn't show before. The sad part about the protein pumps inhibitors is that they actually work. That's the sad part. If you look here, this is endoscopic findings in dental erosion, and they find that, you know, this is the quality of patients that they found erosion with esophagitis and hiatal hernias. And then when they were on the Nexium for 3 years, they found that the amount of wear was a lot less than it was before, because the acid was being controlled. So the word here is, hey, more protein pump inhibitors, the better you are, right? But what's it doing now? We're finding out it may be doing something to your kidneys. So the good part is that they work. The bad part is that they work. And so we just kind of have to keep that in mind, okay? Talked about that. We saw this guy before. Intrinsic acids, we talked about that. Bulimia. It's actually classified as a mental illness. Binge and purge, sorry, young females, okay? Self-esteem problems linked to their body. A lot of them are on Prozac, SSRIs. But a lot of these have some positive results with behavioral training. So that young lady we saw that had the front teeth, just that little circle, if someone intervened with her, she may have been better off. The difference between anorexia is that, you know, they just stop eating, exercise, diet pills, again, young females. They want to get some control over their body, but this is the sad part. There's a high psychiatric mortality rate with these people. So, why do I show this? If we see in some of these people some of the things we've talked about today, and we see they're on certain drugs, and we see certain behavior, and we see certain breakdown of the teeth, and we have a conversation, take them to your office. I notice this and this is going on. I have to ask you a question, answer yes or no if you want to. You find yourself, being bulimic, you have a problem. And sometimes they'll confess to us where they won't say anything to their parents. Sometimes their physicians don't pick it up. But what if we pick something up that no one's ever even asking them? And you say, let's see if we can help you, because this is really hurting. It's going to destroy your life as you go on. And so that puts us in a position to say, are we seeing something that the average physician out there doesn't see? Can we pick up little hints here or there that may help some of these people survive? The same thing with attention deficit, right? So we talked about all of this excess acids and all these things. We talked about medications, chlorinated water, industrial, vitamin C. We talked about the wine tasters in Austria. We talked about this guy and the effect it has. No one took me up on this for $50. The kids, we talked about that. We talked about the amount of soda we're consuming. And there's acid in everything. Look at lemons. Are we still getting those people who suck lemons and we get all that stuff across the front? I can't imagine we still have that, huh? But look at all of your citrus fruits, the erosiveness of them. Even strawberry. Probably the best fruit is pears. That has about the lowest acid content. Then you go to your colas, carbonated beverages, herbal teas, white wine, candies, chewable vitamins. And these guys down here, anything chewable, remember I said a lot of it depends upon the contact with the tooth over a period of time? I think those chewable vitamins just kind of stay on your teeth and they stay longer until they salivate them off, right? So I think their effect is pretty high too. And I said that if you're out with your child and he has a drink, don't tell him to brush. Carry some cheese with you, which we all do, right? We always have cheese with us, right? But that will neutralize the acid, and don't brush until it's at least 30 minutes after they've had the drink. And we talked about the contact time just now and why you have the cheese with you, and ask how they drink, how they eat their foods, how long does it stay there. We talked about the difference between stress and sleep bruxers, the prevalence of these guys. When you look at someone that's 70 years old, here's something we didn't talk about, the catecholamines. These are sympathetic amine compounds. They're released during times of stress. And so when we're doing that and we're in our sleep stress cycle, your catecholamines go out, your cortisol goes up, and your cortisol is your stress hormone. And if anything is going to aid you quickly is having a lot of cortisol in your system. So it's part of the fight or flight reaction here. And that whole cycle of when we go into that stress, the heartbeat goes up, the blood pressure goes up, cortisol is put out into your system, and we're fight or flight. It's life and death. And so we do that 100 times a night. So if they said that sleep apnea and sleep bruxism are so close, this study said if we put them on the CPAP, will they cut down on their bruxing? And they said that it really decreased. So people who were sleeping soundly or more sounder, they had CPAP on, it cut down a lot of their bruxism patterns. Because they were bruxing, remember, to wake themselves up, because the brain said, I'm dying. But if we get oxygen to the brain, maybe they don't have to brux anymore. Okay, so this study showed that there was a decrease. To do a lot of these things are pretty much the same. We talked about how the triangle, how they're involved. I don't want to go into all this again. We talked with these guys. Okay, here's the other thing. I always thought that when you bruxed at night, since you had no control, that you just did it a hell of a lot more than during the day. How do you guys feel? Do you think that's true? Pardon? Pardon? Yeah. Actually, we grind more, we have more function at night, but the force of the function is less than during the day. So during the day, we may not brux as much, but the strength is a lot harder in our bruxing patterns with EMG studies. I always thought we did it more at night or stronger at night. Now when you're bruxing, the force you can put on your teeth is about 250 pounds per square inch. That's a lot of stuff, okay? But during the day, I guess you do that and you're aware of it. I always thought at night, since it was centrally controlled, you can do whatever you want, but evidently it's not as forceful. So did you have a question? I'm sorry. Okay. So that was news to me. This was news to me. Scallop tongue, we talked about the scallop tongue and how to talk to your patients about that. And we talked about a traditional splint. This is a study by Don Gilles Levine. The only part about this was a small study, I think only about 24 patients. But these patients already had a sleep problem, and they put them on a routine night guard other than their sleep appliance. And for a short period of time, when they did this, they found that it exacerbated their sleep problem. So be careful with your night guards. As I said, try to let them get a little bit of a sleep study done to see that you don't want to add to their sleep problems, okay? So, yeah, 40% of the patients got worse. He only had 10, the other study had 24. And so what happens with those night guards, of course, our jaw goes back, the base of the tongue goes back, the genioglossus muscle goes back, and it closes off the airway even more so, if they have a sleep problem. We talked about the traditional appliances, and we talked about this other design that you may want to consider if you think somehow there's a little bit of a sleep component, that you still want to give them something to protect all your veneers and everything else, but you don't want to exacerbate their sleep problem. We talked about the stop bang theory. This is one of the nice surveys to have in your office. Here's a great book by Gilles Levine, who kind of wrote the book on sleep bruxism. We covered this. We covered the different types of evaluations, whether they're pediatric for your kids, or whether you want to go the stop bang for your adults. And this is sad, right? That's sad. Why this little girl, she's got her little beret on her hair, she's got her little crown, right? Why don't she fall asleep at her birthday party? Look in her mouth. Okay, this kid isn't sleeping, right? So we can help these people. I don't know how to have it on a series of slides, but the problem that they had in doing TNAs, they were concerned about non-stoppable bleeding, and so they pulled away from it. Kids had TNAs, it didn't stop, like 1 or 2 kids died. They recently, a couple of years ago, one in Oakland went through that. But they're finding that the percentage of that is so low that they're getting back to doing a lot of TNAs now they didn't do before. The other problem with TNAs, your ENT gets paid something like $300 to $400 to do this procedure. And they're saying, why should I expose myself to that? And here we're talking about money, and we're talking about kids, and we're talking about health, right? But he said, I stopped doing this. I can't, for $300 or $400, it's not me worth going to the hospital to do these things, right? So more and more and more they're going back to doing it. And this poor kid just isn't sleeping. Study for pediatrics, we based on enuresis. I never knew that before. There are a lot of kids who wet the bed. A lot of them are not sleeping well, and it's a way of waking them up and taking a breath other than grinding their teeth. So enuresis is another thing that's pretty big that you can talk to them about. And what I don't like about this slide is for kids, it should be less than 1, not 1 to 4. Kids with the problems, we talked about this in pretty much of the whole study on attention deficit disorder. And look beyond the teeth and evaluate the airway. And some of these kids as early as 5 years old are having problems. This is a study in sleep, the number of kids who have sleep disorders, snoring, exhibit struggles, and just because it's not cute to have your kids snore. It's okay if your bulldog snores, but kids snoring is not normal. So if that's happening, try to get a sleep study done on these kids, check their allergies, look in their mouth, what is the lingual frenum, look at the tonsils. You guys can do that. Thank God for ortho and rapid maxillary expansion, opening up this palate, getting the tongue, giving it space so the kids are no longer mouth breathers. Get the airway, get the air coming through the nose. It's humidified, it's warmed up, it gets the nitric oxide, and with the nitric oxide, the oxygen is absorbed into the cells faster than if you just breathe through the mouth. So it's critical that you do all your breathing through your nose. So anything that clogs you up, and it also affects if you're nasal breathing as opposed to mouth breathing, you have to mouth breathe about 20 times faster to get the same amount of oxygen absorbed than if you breathe through your nose. So if you're going through exercise or whatever, try it. Try to exercise and just breathe through your nose. It's a little harder at first, but you'll get used to it and you'll find out it's more effective. Cyclic sleep, temporary loss, physiologic consciousness. And when we are in our REM sleep, we are essentially paralyzed. Deep sleep, and we're almost paralyzed. You ever wake yourself up in the middle of a REM sleep, and it's like, oh my God, or stage 4 sleep, you wake up and you can tell you can hardly get out of bed. It just depends on where in the sleep cycle you woke up, right? And our favorite is not waking up in our best dream in our REM sleep. And why do we sleep? We talked about this. This is interesting. Years ago, I had the privilege of working on some of our POWs. And we're talking to them about the torture they would go through. And they said the physical torture was bad enough, but the worst part was that they weren't allowed to dream. So they'd watch them, and when you go into your REM sleep, you kind of get the little eye starts flickering, so they knew when they were REM, and they'd wake them up. So a couple of days of not being able to dream, for them, broke them down more than all the physical beatings. And that's how powerful the sleep is and going through your whole cycle, which was kind of sad. And we almost preferred the beating other than not being able to dream. So your circadian rhythm, most of us are from the same one. Your melatonin starts about 9 o'clock at night. But if you're up late, then the melatonin doesn't start till over here. And if you're getting up here, it takes a while for that to be effective. So lights in your room, we talked about all that. It keeps the melatonin from being productive. You're smartest at about 10 to 12 o'clock. The best coordination is over here. Body temperature, I don't know, I'm a klutz no matter what time it is, but I guess the best time is at those times, right? The other thing that fights your sleeping is the adenosine in caffeine. So you're drinking a lot of coffee, and there's 2 factors that make you want to sleep. Your nervous circadian rhythm wants you